join us and look forward to hearing your comments and learning about your experiences with trying to obtain healthcare in Vermont and what suggestions you would have for improving that. We're going to run through a short presentation just outlining the issues. We will get to a set of thought questions just to kick things off. And then we really want to spend the vast majority of this 2 hours hearing from you. So with that, I'll say that we are recording this so that we can make a transcript and make certain that we accurately capture what you're going to tell us. We do have, I think, some staff from the Green Mountain Care Board and the Agency for Human Services who are listening in. We may have some legislative people on the call, and if so, I would ask those legislators to please identify themselves and make any comments they wish to make.
Good afternoon. This is Representative Jim Carroll. I sit on the Commerce Committee and I represent Bennington District 5.
Thank you, Representative.
And I'm Representative Mary Morrissey. I'm on by phone, and I serve in the Institutions and Corrections Committee, and I represent Bennington District 5.
Thank you. Others? Okay. Shadera, if we could go to the next.
Any hospital staff or physicians on this call identify themselves? I'm trying to gauge like what kind of who's in attendance, the complete picture.
Okay, good question. Do we have any hospital staff or physicians on the call?
So maybe I can start. This is Tom D. I'm the CEO of Southwestern Vermont Healthcare.
Okay, thank you.
This is Trey Dobson. I'm the Chief Medical Officer at SVHC, and I'm a physician with Dartmouth Hitchcock Medical Center.
Thank you, sir.
I'm Leslie Keefe. I'm the Vice President of Corporate Development for Southwestern Vermont Healthcare.
Okay.
This is Connie Jastrzemski. I sit on the board of Southwestern Vermont Healthcare. And I'm a nurse.
Robert Lava, Vice President of Finance and Chief Financial Officer of Southwestern Vermont Healthcare.
Okay.
Rich Ogilvy, Chief Information Officer at Southwest Vermont Healthcare.
Okay.
Jim Schmarkey, Director of Southwest Vermont Healthcare.
And so several. Thank you, and thank you for the question. Next slide. I want to try to get through this presentation so we have time for you all. So Act 167 requires the Green Mountain Care Board and the Agency for Human Services to develop and conduct a data-informed, patient-focused, community-inclusive engagement process to assist Vermont's hospitals in reducing inefficiencies, lowering costs, improving population health outcomes, reducing health inequities, and increasing access to essential services. An additional one is to preserve capacity for emergency services and needs. Green Mountain Care Board has asked Oliver Wyman to conduct that process. I'm a partner and the Chief Medical Officer for Oliver Wyman's Health and Life Science practice, and we'll go through the introductions in a bit more detail in a minute. What we are doing is that we've spent some time getting data and getting organized, but we are conducting listening sessions with a broad variety of groups, and I'll go through those in a minute, including both general community meetings such as this. We've got 14 of those scheduled. We have 4 statewide community meetings scheduled. And we have currently 14 meetings scheduled with healthcare providers, broadly defined, including nursing home people, EMTs, nurses, advanced practice people, home health agencies, and so forth. We're conducting virtually multiple rounds of meetings, 93 roughly scheduled between mid-October and Thanksgiving. We're doing these virtually so that more people can attend and we can get, broader representation. But what we're going to do then is take your comments and experiences, take them together with the data available and the reports from the state on issues as broad as manpower, information technology accessibility, needs for chemical dependency and substance abuse and so forth, and formulate a series of options to be considered to improve hospital sustainability, that is survival over the next 10 years, and how to improve the services provided in the community and the community health. So, sorry, shutting the door. We will then subject those things to intensive analysis to see what the impacts of those changes might be. And we will come back to you and to the hospital board and executive group in the spring in person. So we've talked, I think, to all the hospital executive teams except one. We've talked with some of the boards, not all, but what we will do in the spring is come back and have a meeting with those groups jointly, and follow that by a town hall meeting style in the community to get the community input on those potential suggestions. And we will then go back, take those comments into consideration, and formulate a final set of recommendations to the Green Mountain Board, Care Board, which will then go to the state legislature, which will then come back to the hospital boards and communities. So multi-step process, lots of opportunity for comment and feedback. Your comments and experiences today will be very important in how we think about going forward. So, as noted, we are really trying to focus area by area on what the local needs are and priorities. Those are very, in some ways similar, but also in many ways very different between the communities. Next slide. Okay, so this is our team. I'm a physician, I'm leading it. I have 52 years of experience in healthcare delivery, education, run 2 large hospitals. I serve on the board of one in Bozeman, Montana, 140 beds. We have a critical access hospital. And for the last 10 years, I've been at Oliver Wyman, assisting hospitals, health systems, and a couple of small foreign countries to redesign their healthcare systems to improve access, reduce cost, improve quality, and so forth. We're being assisted in this by Ms. Elizabeth Sutherland, who has her master's degree in systems engineering from MIT. Elizabeth and I worked together for 10 years at Oliver Wyman. She recently moved to a different firm, but she's leading the healthcare equity part of this effort. She has worked to staff the Pennsylvania Governor's Commission on Health Equity and has also done similar projects in California and San Francisco. Sam Winter is our engagement manager. He takes care of all the complexity and the details of making this thing run on time. And our 2 consultants are Dr. Chidera Chewicki, who is a neuropharmacologist, has expertise in addiction, particularly alcohol and tobacco, and has been working the last few years at Oliver Wyman on a government payer issue, so Medicare and Medicaid. And Gretchen Gonzalez is a consultant who's joined us, who's doing a lot of the data gathering and so forth. So a fairly broadly based team, I think a fair amount of experience. And I've done some previous work in Vermont, live not too far from you in central Massachusetts. Next slide. Okay, so this is what we're doing. Introduction, the maximum amount of time possible on gaining your experience and perspective, and then a little bit of closure on how you can continue to provide input. Next slide. So, basically makes the point, Vermont has been quite successful in getting its people insured. The problem is that of Vermonters less than 65 years of age, 40% of those with insurance are underinsured. That is, can't afford the out-of-pocket costs for deductibles, co-pays, prescription drugs, or over-the-counter drugs. So it's a big issue, as we'll show in a minute. Next slide. This shows the premiums, which are paid for by hopefully the employer and the family for both silver and platinum plans. Platinum, of course, has the less amount required in deductibles and copays. You see that the premium for a platinum plan in 2023 is almost $40,000 in total. The median family income in Vermont in 2020, according to the census, was a little over $67,000. And once you take taxes out of that, federal and state, take home's about $43,000 a year. And you see to the lower right, even with a platinum plan, if somebody gets sick, you're looking at almost $5,000 in out-of-pocket expense. So 11% of the family budget, just not doable. Next slide. This is median wait times in days to get to a specialist at the various hospitals in Vermont and Dartmouth Hitchcock. And you see the median's 48 days, ranges dramatically. This is data I helped collect about 18 months ago, clearly hadn't gotten better. Next slide. So access is a problem, cost is a problem, and being driven also at a national level. It's a problem everywhere. So orientation. I've talked about what we're trying to get, what we're going to do with it. We're not really able in this forum to talk about individual needs. So we need to refer those either to the healthcare advocate for the state, as a staff of 8, and I know they're very busy, but they'll try to help. Telephone number and website there. Would ask in terms of housekeeping, you please stay on mute if you're not speaking. Please use the raise your hand feature and we'll certainly call on you. We'll also stop periodically and ask for comments from those on the phone. If you can, try to keep your comments brief. We do want to hear from as many people as possible. And we have about 60 folks on this call. So really would like to learn from as many people's experience as we can. So we'll go to the last slide for us. Please, with the, okay. So these are sort of the issues that we're interested in, but obviously interested in others that you care to bring up. How would you describe the process and your experience in seeking and receiving healthcare in Vermont? Have you been able to get it? If not, why not? If so, what worked? What could be made better? Have you or your family encountered issues that are specific to your situation? Either not being able to travel, having a mental health issue, an ethnical difficulty, or language barrier, or anything like that. So I'm going to stop there. and ask for questions or comments. We have an hour and 45 minutes. Please, Ms. Silsby.
Hi. I defer. I'm putting myself back on mute and we'll come back.
Okay, thank you. Other comments, please. I can outwait you.
I do. I just don't know how to raise my hand.
Yes, please.
So one thing with the affordability, and one issue I started a new job. I was on state insurance. I guess I'm just wondering how come they don't base, like when you apply for like food stamps for say, they take in both what you make for income plus what you pay for your bills.
Yep.
And that's what they go from. With the insurance, they don't take any of that into account, which is pretty unfortunate because I lost my state insurance and now having to pay through my employer for insurance, which is making it really tight with all the premiums and copays and deductibles and all that. So I guess that's one big thing. I'm wondering why the state does that for one service, but for healthcare it won't.
Okay. And so the when you deal with the hospital or the provider, they're not adjusting the payment to your payment to your ability to pay.
No, I'm having to actually file a financial partnership, some paperwork I have to fill out to see about that, but it's another process to take to see and time to wait. Like right now, I had an ambulance bill for $1,800. I have a $500 just for a urgent care bill, and then I have a $300 for the rest of the hospital bill. So,
Okay. Oh my goodness.
yeah, because my insurance wouldn't cover until my deductible was reached. So,
all right.
and
Thank
I just
you.
work at an elementary school. So,
Okay.
Thank you.
Thank you for that information and comment. Ms. Jacobson.
Hi, I'm in Bennington, and my major concern is the critical shortage of doctors that we have in our area. My doctor was kind enough to give me a lot of lead time when he decided to retire, and it became a really anxious situation. I called from 10 miles south of here to 25 miles north of here, across the border into New York State. There was only one doctor's office I could even get on a waiting list. And I was told I was between numbers 1,800 and 2,000 on that list.
Oh my goodness.
Yeah. And I finally got into a doctor up in Manchester, and I had to call because I'd been sick for several weeks. And I said, could I, get an appointment with my doctor? And they said, well, there's nothing available. And I said, it's not urgent. Couldn't you fit me in next week? And they were able to fit me in the following week. But when I asked the question, if I had really an urgency to get in, could one of the other doctors in that practice have seen me? The answer was no. I said, well, what would I do if it was urgent? Then they said, well, you have to go to urgent care. How many people is urgent care going to be able to accommodate? I need a primary care doctor. I'm in my 70s now, who knows me.
Yep.
And I just find the whole situation extremely stressful.
Right.
And I want to know, is there one more thing? Is there something that we could do? I know they've been trying very hard at our hospital here in Bennington to recruit new doctors.
Yes.
But is there something beyond the ordinary that can be done? Can we somehow find financing to help doctors with their medical school bills, to help them so that they can come and work in a rural area like ours? Something has to get done, please.
No, you're right on target. That is part, as I understand it, of the state manpower plan. Some of that you've mentioned, support for education and those sorts of things. And it applies not only to physicians, but also to advanced practice people and and other
Yes,
sorts of healthcare professionals. So, but unfortunately, it's going to take some time to solve. I mean, medical school and training is at least a 7-year process.
but there's people coming out every year.
Well, there are, yes, and that's true. And so, as they can be enrolled, it could happen sooner, certainly. Thank you.
Thank you very much.
Ms. Hillsby.
Thank you. So, when you were giving us your introductory presentation and presenting the slide on healthcare costs and median incomes, and when I listened to the other two attendees speak to healthcare needs, what I'm experiencing, my husband recently passed away, and I was very, very fortunate with the hospital that provided palliative care to him. They were miraculous in how they made sure that I didn't receive any bills. I mean, when you're talking about a terminal illness, your co-pays quickly add up and you meet your deductible.
Right.
But what I'm realizing is I continue to have conversations about healthcare in Bennington County and beyond. It's not the doctors and the hospitals per se that are driving healthcare treatment and meeting patients' needs. It's our insurance companies telling the patient what they will and will not pay for. And that's frustrating because, and I look at the doctors and the nurses that are on this call right now, I'm pretty sure that the person processing the paperwork at the health insurance company that I have, they don't have a medical degree. And so why are they dictating what treatment and what prescriptions me or my family members need? And that it's really what they're willing to pay for. And if I look at these questions that are up on the slide, I would say that we are more of a treatment-focused healthcare than a preventative healthcare system. So we go to the last speaker. We go when we're sick, right? But we don't go per se to prevent something from happening.
Yeah.
We don't get that kind of level of care.
Right. No, thank you for your comments. It has been said the U.S. has the best rescue healthcare in the world, but the poorest preventive care. But thank you. Noted. And there was also a note in chat about the importance of nurse practitioners and PAs and advanced practice folk, and absolutely noted, and a shortage of those folks too. Let's see, Ms. Mulhern.
Thank you. I just wanted to share some feedback regarding the challenges to accessing healthcare. One is definitely cost, because if you pay for private insurance, the cost is astronomical. It can be about 25 grand a year for the silver or gold plan of Blue Cross Blue Shield, which is actually increasing. And then mid-year, what we found over the last 2 years is during COVID, the private insurance has decided not to cover prescriptions previously covered, or has required prior authorizations, or has decided not to carry that particular, I guess, DME, and has decided I'm going to go with we're going to cover a different brand of like a diabetic sensor, for example. So what happens is there's this inconsistency with care as well as with treatment. You could have the best treatment plan and have it totally upset by your insurance because they no longer cover that medication, or that like if the medication is a pill versus a patch. So I actually had appealed something recently to Blue Cross saying, you're not part of my treatment team. You've never made a phone call to me or spoken with my physicians, and you're making decisions about my care that actually jeopardized my life. So it's really incredible. There's also a huge economic discrimination out there.
Yep.
If you have private insurance, you may be accepted, but if you have Medicaid, you're not. Physicians are no longer accepting Medicaid patients. They're refusing to bill Medicaid as a secondary, which is hugely challenging for those families that have both and pay for both. And then you also have the lack of providers, and I must say lack of specialists. We have no psychiatry and psychologists in the area. I have traveled to Springfield, Vermont for a specialist in autism, or Wallingford, and I live in Bennington. I have gone to Rutland for a pediatric dentist for 2 disabled children. I have gone to Boston for my own care because someone specializing in my particular diagnosis doesn't exist in the state of Vermont. So we have, to see dollars go elsewhere and outside of Vermont is disheartening. And the lack of providers is huge.
Right. Thank you. Very notable experiences, and appreciate the comments and the information and the examples. Thank you. Mr. Williams.
Thank you. I had occasion to, unfortunately, be in the emergency room of the hospital in Bennington over the last 2 weeks. And my experience was extraordinary and wonderful, frankly. I'm not completely out of the woods, but that's not the point that I wish to raise. The point I wish to raise is that our hospital has invested hugely in our new emergency room, as you know.
Yep.
And I'm witnessing how people then will use it and how that becomes more expensive to the state, more expensive to the insurance companies, and otherwise. Notwithstanding my own personal experience, which, as I say, was extraordinary, and I'm quite pleased to be able to report that, I see that these urgent care, and actually more importantly, for more serious circumstances, emergency rooms will be the focal point for people to go to the doctor, because it is so hard to find primary care physicians. And then, of course, we have the interdisciplinary nature of various needs that a patient may have or otherwise. And I'm wondering whether or not Green Mountain Health Board is aware and can perhaps, if in fact this is the manner in which we're going forward with, because of the nature of medicine and the nature of dollars spent or otherwise, there needs be then a larger, much larger investment in emergency rooms. Where you have to go to a hospital room is another matter. But in truth, that's where the rubber meets the road with people who are seriously ill.
Yeah.
And I was treated properly, and I'm here speaking to you about it.
Good.
Sufficient to say that that notwithstanding everything else that has been said before with regards to cost, with regards to access, and otherwise, our senior senator, and his plan for a national health care, were it to be implemented, in my opinion, is the way to go. It is a basic right of human life, not unlike education. And I know others of my family members are advocating for such in Massachusetts and otherwise. We need to process this information and move it along. And that's all I'll say at the moment.
Thank you. A quick question, sir. Your care after the emergency room visit, how did that go? If you needed additional care.
I do, and I have. And I have been able to make appointments and see physicians going forward to assess what's going on. And there's one further point that is important here. The nature at which all the various specialties integrate as relates to the health of an individual participant is critically important because, and I should say as well, hopefully the intelligent recognition of the patient as to what's going on in their body themselves, so that the various, be it neurosurgeon, be it a nephrologist, be it a cardiologist or otherwise, is coordinating properly so that all aspects of a patient's health, be it medications or otherwise, and changes in that patient's condition are discussed by all of the team at once so that integration becomes to the benefit of the patient.
Right. Have you found that able to happen in your case, sir?
To a degree, yes, absolutely. However, I have to advocate, I've had to advocate and be aware, and I've noticed this, quite frankly, for myself, by myself, in terms of understanding what's changed in my own body, and as well, what and who would be the appropriate person to be seen by and then coordinated with by the various disciplines.
Right. Okay. Thank you very much for your comments and experience. Appreciate it.
You're very welcome. Thank you.
Ms. Chase. Yeah, you're on mute. You're on mute. Where'd she go? Okay. Ms. Winslow, and then we'll get back to Ms. Chase, I'm sure.
Thank you, Mr. Hamer. I just wanted to make a comment to SVMC. I work with New Americans, and my concern over the past couple of years has been with interpretation services. SVMC has made quite a lot of progress with interpretation services, going from God knows what they started out with was just absolutely horrible. But going to Boost Lingo was a huge, huge improvement. Thank you so much for that. I continue to be a little bit concerned with the lack of experience and training and awareness of the system in some of the departments of the hospital where it's not used very often. And I will go and they'll be dumbstruck that there is a system, and then completely unaware of how to access the system or where to access the system. Although in most places in the hospital, I find that people are warm and happy to help and open to change and open to helpful suggestions. When it comes to working with people who don't speak English as a first language, they can be very, very, very defensive and angry. And they tend to be angry with me, which is interesting, because I won't help them. And I won't help them because I have helped them in the past and it hasn't managed to move things forward. And I want them to move things forward on their own, because eventually I have to back out of the system and let the system work for itself. And when I insist the system work for itself, I become the bad guy. I really need SVMC to own this issue in all of its departments with all of its employees and be their own advocates. So if you could please train all of your employees to at least know who the resource people are. And you've got some great resource people. I mean, if I could advertise Brian in your registration department, he's amazing. You have some great people in the lab. You've got some great people in radiology. You've got great people that are greeters. Use them as your trainers, because they know how to use this system and use it really well. So thank you.
Thank you. Just a couple of quick questions on how are people doing it? Cultural competency? I mean, patients clearly who are coming from other countries have different interactions and understandings and expectations of health and that sort. How's that going?
That can be hit or miss. It's interesting. It's interesting to see that some people are so delicate about not being intrusive that they don't do a physical exam when a physical exam seems really well warranted, because they're afraid of touching someone's body, when the only way to get a diagnosis is actually to touch someone's body, and there's really no way around it.
How about decision making for illness, what to do, or a complex illness?
Yeah, that's always that's hard too.
Oh, yeah.
I've seen it done a lot of different ways. Trey, I see you on the screen. I know it's really hard in the ER to make decisions, or to have people make decisions that you don't agree with.
Yeah.
I've seen surgeons walk into a room and say, "Have you told, what if you told your son about his circumcision?" And the dad go, "Oh no, I've told him he's here because he's got a bellyache." And the surgeons go, "But that's not true."
Yeah. Okay.
and they just have to swallow it because this is
Right.
the pain, and it's a cultural decision.
Yeah. All right. Thank you. I
Interesting.
mean, the understanding and the experience really helps.
Yeah.
Let's see, Ms. Chase, you dropped off, and I think
Yeah,
you're
I
still at the head of the line.
hit the wrong button. Can you hear me now?
Yep.
Okay. I wanted to go back onto one of the previous callers about the lack of general practitioners in the area. I'm in West Dover, Vermont, and my husband had an accident Memorial Day weekend. The care he got at the hospital was extraordinary. The doctors were amazing, from the ER to the case managers. Very, very happy with that. But he had 3 surgeries and he had an infection, and they would not release him unless he could get his intravenous done at home. His intravenous done. Rehab was out of the question. We could not get, even though I have been a patient in the local Wilmington Deerfield Valley Health Center for over 10 years, and he's had blood taken there, they would not take him in as a patient. So I spent an entire day with the case managers trying to find visiting nurse. There was no visiting nurse association that could see him. There was only Biata. They were full, and they would not come to the house. I tried private care duty nurse, could not find a private care nurse, and eventually had to make arrangements to go to the VNA in Manchester once a week for his intravenous, his PICC line changing. We were able to find the Northshire Health Center that would take new patients, which I dropped paperwork off in August. Still have not been able to get the paperwork done. There was a miscommunication. I never got a call. He cannot be seen by a doctor there until he has a consultation. Their consultations are 3 to 6 months out.
Yeah.
And it's really hard to figure out healthcare that way. So the visiting nurse not being able to have somebody come to the house, not being able to go to a local doctor here, it's really horrible. Yeah. It's a really horrible situation. And, he's been in that hospital because he had the hip replacement, had an infection. They wouldn't release him. He was there until they found, he was there more than he really needed to be, because they would not let him go without the correct care, which I appreciate. It's just very, very frustrating. And the other thing is the shortness of medication. He couldn't get the medication that he needed. It was back ordered. Luckily for us, he could take it orally, so that was better for us. It was only the one PICC line he had to go to the VNA for, and they were great, but it was traveling an hour back and forth to get the blood tested every week, to get the PICC line changed, and back and forth. And it's just very frustrating.
How about rehab after the total hip?
He is actually doing the rehab in Connecticut. He's there 3 days a week. He's there 3 days a week, and he gets it there.
I see. Okay.
Because his business is in both places. His business is there and here. So he goes to an office there, but he has an office here.
Okay. Thank you very much. I really appreciate the detail and the experience. We've heard similar things about unavailability of home-based care elsewhere, but really appreciate the comment.
Okay.
Ms. Valentine?
Hi. Thank you for this opportunity to contribute. So I represent a little bit of a different demographic. I live in New York State in Cambridge, New York, but I am in the service area of Southwestern Vermont Medical Center. I'm also on the Community Regional Advisory Board from this area. And I am seen at for primary care Northshire. I'm very grateful to have an excellent primary care provider there. I can also attest to, I think, the impact for people who do have primary care providers. So there's still an impact of provider shortage and wait times to get appointments. So I just wanted to share that. And then I have two other points. One is from being on the Community Advisory Board, I've had some insight into ideas and beginning initiatives and developing initiatives on the part of SVMC to develop further kind of transitional programs for primary care providers and other forms of support to attract primary care providers, both physicians and nurse practitioners, and I believe possibly also physicians as associates. So I guess what I'm bringing forward in that is that I think that to the extent that the Green Mountain Health Board could support those efforts, I think that could be of tremendous benefit in increasing the number of primary care providers who opt to stay and work in the community. And then finally, I just want to say that I know most of the focus of this conversation is on primary and specialty care and direct care, but as you may know, hospitals also have, nonprofit hospitals also have community benefit obligations to look at the determinants of health within a community. So, so I think, looking at things like poverty in communities, like environmental pollution, like conditions that lead to increased levels of substance abuse. I just wanted to put forward that I think that to the extent that on a statewide level, there can be support for hospital initiatives in those areas. And that's it. Thank you.
Are there thank you. I mean, absolutely crucial points. Vermont has a number of agencies and people targeted at things like substance abuse disorder and other issues and home health. I mean, a number of those things are in your experience. Now you're in New York State, but in your advising the hospital, do those other programs seem to be integrated? Some of them receive hospital support, certainly.
Yeah, and thank you for raising that, because I think that although we are in the service area, there still are, and I don't know all of the details on this, but I understand that there still are some restrictions in expanding some services that are offered by the hospital to New York State. I live in Washington County, so we don't have a hospital in Washington County. Something like visiting nurse services is those types of services are very limited in this county. So, so I think that is an issue that could be looked into further, is how those services might potentially, when they exist, when they're further developed, how they might be opened up to the service areas in New York as well.
Right. Thank you very much. Appreciate your comments.
And then I will just add too that certainly in Hoosick Falls, New York, that as well as in areas near Bennington, that exposure to PFOAs has become, is a major health concern. I know the hospital is getting involved in some monitoring of that, but I just want to hold that up as kind of, an example of kind of the question of, is there a role for hospitals to address those kinds of issues? I think that's an open question, but I'd like that to kind of be on the table.
Great, thank you. Ms. Kleinfahler? Wendy Kleinfahler? Comment? Okay, Ms. Mulhern.
I just wanted to add one more piece of feedback, and it was in regards to a very sensitive subject, and it's concerning mental health.
Yes.
And the need in the community, of course, for mental health services. I do understand what UCS does, and that we have a new section of the hospital. Thank you very much for dealing with those in crisis. But I do want to mention that I actually, when it comes to mental health diagnoses, healthcare can be a little blurry. And oftentimes, those that have mental health diagnoses, some of their symptoms can be ignored or it attributed to a mental health diagnosis instead of a medical, I guess, problem. So I just wanted to relate to you how those perceptions can actually inhibit healthcare and appropriate treatment, but it can also have trauma effects on those receiving care to the point that they don't seek out care, especially emergent care, because of, perhaps the way that they were viewed in the ER or at the regular physician's office. So I do want to say that mental health should be a priority, of course. We all can't do enough because obviously things still happen, but I really think that we need to look at that bias and kind of remove that somehow so that they are looked at medically appropriately, I guess.
Right. Important point. Thank you very much. And that's been clearly an experience you've had. Key point.
Yes.
Thank you. Margai, no other identification, so.
Hi, thank you. I'm Margai Diamond. I'm the Executive Director of Turning Point Recovery Center in Bennington. So I have some comments from that perspective. The population we serve of folks who are in addiction, in recovery, in treatment, any one of those points of the spectrum. We have Turning Point recovery coaches that are on call 24/7 for the emergency room. And so we are called when someone comes in with substance use disorder. Used to just be really focused on opioid disorder, but I'm really happy that we've made progress in really identifying alcohol use because that is the bulk of what we see, believe it or not. I wanted to just comment on how great the staff works with us and engages coaches to come and talk with people. We do, you'd think we do a lot of coaching, but we really do a lot of navigating for people. The continuum for folks is really unacceptable at this point. And that has a lot to do with insurance and at a state level being negotiated. I understand that. But what Medicaid pays for, just so everybody knows, is, 99% of our folks are on Medicaid by the time we get to them. And they have a choice to go to treatment up in Virgins or Bradford. So they've got to figure out how to get there. And Medicaid currently pays for the equivalent of 14 days. Now, one of those treatment centers is called Valley Vista. Our patients report back to us that there's certainly not a sign out, but they all call it the Vermont wing and the New York wing. And the New York wing people get 28 days and the Vermont wing people get 14. So I won't go into the whole chain reaction after that, but 14 days is not enough. And it has been standard in other states to provide at least 28 to 30 days. 90 would be optimal, but at least 28 to 30 days. So that's just, that's a higher level discussion. But what we have is a revolving door on this situation right now. I've seen it in action and it just goes on and on. It's like a hamster wheel. So people come into the emergency room. The emergency room has been great about, like I said, calling coaches. They've been great about trying to get people rapid access to medication, which would be opioid users getting Suboxone right away, alcoholics getting Librium to take home. We have made a lot of progress on the side of being able to keep people for alcohol detox. Because as you can imagine, sending someone inebriated home with a bottle of Librium to take as prescribed doesn't really go very well. So I just can't commend enough the ability to have people stay for 5 days and be medically detoxed through alcohol, whether they're at risk for a seizure or not. Now, in my dream world, we'd keep the opioid people too. And of course, we got a whole basket of stimulant users, which is on the rise. Most of their stimulants, majority, almost all, are contaminated with fentanyl. So they're being treated for opioid use disorder. We don't really know what to do with stimulant people. But I really think that I know it's not cost effective right now, but again, I think this has to be negotiated at a higher level for the hospital to be able to provide detox for people, period, whether it's opioids or alcohol. And the reason, I'm just sorry, but I was one of those people. I had to be babysat. And what happens when people get released from the ER and we can't get them a treatment bed for 2 weeks? They relapse. Of course they do.
Right.
Because they're going back to the same environment with the same people. They need to go from detox right into treatment. No gap in the ideal world, right? But that 5 days of getting someone stabilized before they head into their illustrious 14 days of treatment gives them a better shot. So I just, I think about ways when we talk about cost reduction and inefficiencies, it's like we're short-terming the game here and paying in the long run.
Right.
So we need to really adopt some effective treatment procedures, detox, specifically with the hospital in mind, on both ends of the game, cover all substance use disorder, and get people, like, at least give them the right footing to move into treatment. And then if we can solve that, that would be amazing. And get people at least 30 days.
Right. Thank
I
you.
want to say that the stigma is just one last thing I want to point out. And I think that in general, I would say people are really great. I understand the compassion fatigue, but I do still think there's some education to be done. So I have a specific example of someone who was a chronic alcohol user. She'd been in the emergency room. She tried to stop on her own, had a seizure, ended up in there, and she was seen by a doctor. Fast forward another month, she had started drinking again. She decided to quit, had another seizure, back in the ER, was being attended by a different physician. But the prior physician she'd seen the first time saw her name on the board and decided to pop his head in the room and look at her and said, "Do you remember me?" And she said, "Yes." And he said, "Well, you didn't learn your lesson," and walked out. So I give you that as an example. It's definitely few and far between, but it still just begs that constant education. This is not a choice that people are making. They're sick. And most of it is co-occurring, and there's mental health issues involved as well. So I just want to say all that. Thanks.
No, thank you. And the revolving door and the need for appropriate care downstream after the emergency room, critical. So we are trying to think about those things too, and how to spend more money more appropriately, if that's the right term. But thank you very much for that experience, and really appreciate the work your group is doing. Let's see, Ms. Kleinfowler, are you able to? Yeah, there you are.
Yes. Yes. Hi there. Thank you for taking my call. I'm sitting in the parking lot at the hospital, having come out from a physical therapy treatment, and didn't want to go into a no cell zone area on my way home. I am a 7-year survivor of multiple myeloma, so I'm an active patient at the cancer center here, and have used many of the services of the hospital, and have to use this as an opportunity to give a shout out to the folks at the cancer center over the years, because of their skilled work. I am here to at least share my experience with the crowd. The one thing I would like to point out, because of my particular illness and its trajectory, I have used, I've had procedures, a stem cell transplant at Dartmouth Hitchcock 7 years ago, and most recently a CAR T cell therapy at Dana-Farber in Boston. So what I want to speak to is sort of the information technology or medical records system. While the skillfulness of the physicians is really miraculous, and I can't say enough about the healthcare team here. I do have to say that one of the frustrations that I've found in my experience over the 7 years is the incompatibility of the medical record systems, even between the cancer center and the hospital system, the medical records here at the Cancer Center and Dartmouth Hitchcock, with whom we are now partners, and the medical record system at Dana-Farber and here. Just many people who have serious illnesses or chronic illnesses are seeking specialty care at affiliated hospitals. And it would seem to me in today's world, there's got to be a technology compatibility between those systems that would allow easier sharing of medical records and data. So I wanted to throw out both kudos and just a suggestion or a question about what we could do to make that system speak easier. I also want to just share an experience in that during COVID, I was able to do follow-up appointments via telehealth with the oncology specialist I had seen at Dartmouth Hitchcock. When post-COVID, I had to travel the 2.5 hours to Hanover in order to see that doctor, while I could transfer my care to Dana-Farber in Boston, drive 15 minutes to a friend's house in Williamstown, and jump on a Zoom with a doctor in Boston because I was in the state of Massachusetts. And it seemed quite ridiculous to me that we can't do telehealth across state lines in our region,
Right.
at least with the hospitals that many of us seek specialty care.
Okay.
And I don't know why that might have been, but it was one of the reasons I decided to transfer my care to Dana-Farber from Dartmouth Hitchcock, because I could do my telehealth 15 minutes from my home.
Right. No, great example. Thank you. Noted and agree about telehealth. I suspect the reason the difficulty exists for both Dartmouth and Dana-Farber in Vermont, as in many other states, is licensure requirements for the docs that they have to be licensed in Vermont. But we'll ask and certainly take that into consideration. Thank you very much for your comments. Ms. Tilley.
Thank you.
Hi, I just wanted to share some feedback around access to care for low and no cost services for reproductive health and gender affirming care with the closure of Planned Parenthood in Bennington about a year ago. That is something that we have a college in the community, and we have a pretty significant youth population who likely were accessing services through Planned Parenthood in the past. And granted, there's some capacity in neighboring counties to provide telehealth appointments and services to that population still. But I think people are really struggling in the Bennington service area who had been accessing care through Planned Parenthood. And that population is often faced with other socioeconomic challenges and social determinants of health around transportation, financial prohibiting factors that prevent them from being able to receive care in a location that's 30 to 60 minutes away.
Right.
And I just hope that I know that there has been some significant efforts at the state level around education around health equity and inclusive care measures, but I just hope that that will continue and be expanded upon because it's desperately needed, especially in the southern part of the state.
Okay. So is that, I mean, so access to Planned Parenthood, education, and more access to the gender affirming care and adolescent care, has that not been available outside Planned Parenthood, or difficult? You've said difficult to access, certainly.
I think it ties into the fact that there's limited primary care access and limited specialty care access. So if you're talking about receiving reproductive care, you're likely going through an obstetric office, potentially a gynecology office. Or if you're trying to receive care in a primary care setting, access has been so limited over the past couple of years that on top of being able to find just a general access to care, being able to find gender affirming care on top of that becomes even more of a challenge.
Right. Is it an issue? Well, certainly an issue with the availability and number of providers. When you find a provider, is it an issue at all in how that care is provided or perceived by the provider?
I think, having worked with many individuals in the queer community, a lot of the feedback that I receive is that if they are able to, they are willing to travel significant distances out of our service area to receive care where they feel that the providers are super competent in gender affirming approaches, compared to feeling like they are kind of just skating by with sort of baseline knowledge. There are a lot of really skilled providers in the Massachusetts area. People are traveling to Northampton and Boston on a regular basis to receive both medical and surgical gender affirming care. And that's, I would love to see that become more accessible for people in the community that they live in.
Okay. Thank you. Appreciate the comments very much and the examples. Others, please.
Can I just jump in? I hope someone's recording the chat messages because there's good, okay.
Yes, thank you. Yes, I haven't noted them all, but we are, and greatly appreciate any comments or suggestions. We've even had people in other sessions send us web links to other information. And so any of those techniques, let me pause just for a minute. Are there any folks on the phone who wish to make a comment? Okay, Ms. Mulhern.
Sorry for jumping yet again. I just wanted to express the need for dental care.
Yep.
Huge, 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 huge in this area. Sorry about the dogs.
I've got them too. So dental care, is that both an adult and a child issue, or children particularly?
Yes, absolutely. And especially those providers that are willing to accept Medicaid, because as I said, I've traveled to Rutland to find appropriate providers for my children, and around here, an enormous amount, we have providers, but they're full. They're not accepting new patients and they don't accept Medicaid. Actually, recently I tried to find a therapist, and one of the therapists doesn't take insurance at all. So you're torn whether to, if you don't have a provider that accepts insurance, you don't get the care you need. So, but dental care is huge, huge here. We just lack in providers immensely.
Okay. Thank you. Mr. Vernon.
Hi, my name is Matt Vernon. I'm actually the radiation oncologist down at SVMC. figured I could pipe in with a little bit of a provider perspective, if you like.
Please.
I mean, there are obviously numerous problems. We've been watching the healthcare costs spiral out of control even before the pandemic and inflation and everything got so expensive and so forth. But really, it's just been, I guess, in this last year that I've felt more and more that we're being asked to do more with less. It's difficult to get new capital purchases. It's very, very difficult to find staffing, nursing staff, and other office support staff. And those that we do have on our team are increasingly being asked to spend their time getting prior authorizations, fighting with insurance companies, and the providers themselves as well. I mean, we spend a lot of time on the phone with the insurance companies trying to get peer-to-peer authorization to appeal adverse decisions. Even more than that, I think that many of the payers are putting up just sort of a rubber stamp denial and forcing providers to go to a peer-to-peer because they know that it's a deterrent, that we don't have the time to do it, and that if we can skate by with something lesser, that somehow we will. But for me, at least personally, that stuff doesn't get me up in the morning. That's not why I went into medicine. I've got better things to do with my time than worry about who's paying for what. My paycheck looks the same regardless of what I offer. I work for a nonprofit health system. That's not what I'm in it for. I'm just here to provide care for patients and to do what I genuinely think is going to be in the best interest of my patients.
Right. So what I'm hearing, I mean, I'm hearing this a lot, and it always, my specialty was infectious disease, so I didn't have quite the same issues you've got, but it interests me that a specialist and a subspecialist who's an expert in a certain area is having to get pre-authorization from anybody for care that they believe is necessary and within their area of specialty. But I'm not only hearing that from you, I'm hearing that from a lot of our colleagues. So
yeah, absolutely. I mean, radiation oncology is a super technologically driven field. It's got a lot of overhead, and there are cheaper ways of doing it and more expensive ways of doing it. But again, we're a nonprofit hospital. We don't have any reason for the payers to suspect that we're trying to inflate our reimbursements. We're just trying to treat patients and do what's right.
Okay. Thank you very much. I just comment, Dr. Vernon, we are having provider-oriented meetings at the HSA level. I think we'll have one. I'm sure we'll have one scheduled with you. So you're obviously welcome to attend that. Would encourage your colleagues to attend that. But thank you very much for the observations and the experience.
Great, thank you.
Let's see, Ms. Wood. Yes,
Hi.
ma'am.
Let me just preface this by saying that I have only lived in Vermont for about 8 years full time. Prior to that, I lived in Boston and worked at one of the major teaching hospitals there. And it's so sad that almost all of the topics that are coming up today are issues that I've been hearing for the last 35 years, it seems. We've made so little progress. It's sad. I've had a multitude of jobs in that healthcare system over the years, not the least of which was working in a medical record department, to Wendy's point. And I have to say that our CIO was actually served on the Office of the National Coordinator for Health Information Technology.
Mm-hmm.
You may know him.
I do.
And we were lucky enough that our record system there was a homegrown system. And although we were the mothership hospital, so we were able to develop a way through what we called our magic button, so people could actually get into the record systems of other hospitals, which was great. But it took a lot of work. There was a huge effort behind that. There were millions of patients in our combined master patient index that I had to help manage. So it's that in and of itself isn't an easy thing to solve. So the way Epic seems to be going and taking over the world, who knows? Maybe we'll get there someday. But having said that, my husband has had to access lots of health services through the system, and in general, things have been great. He did have to go to St. Peter's one time. Bless you. And we ran into the same problem we were able to access his records through the portal, but of course the physicians couldn't, and it was the old, we'll fax them to the office thing, and then they get lost. And because I understand the issues more, I can be a little bit more patient, but he gets very frustrated, as I know lots of patients do. So it's a tough thing. And I know Matt through another part of our lives, and my heart always goes out to the providers. I mean, the providers have been great to us, but I can just see that they're overworked. And what can we do together to make things better? I think it's a huge issue. And I think that because there's so much, head banging on things with the same old issues over and over and over again, the prior authorization, and I have to laugh because we have regular Medicare, which we decided to stay with. So we didn't have authorization issues, but we still have to go through authorizations, which I wonder about sometimes. I think the other big thing for, we, as I said, we're on Medicare, so we're at the older end of the spectrum now. A lot of the specialists we've had to travel to see, and we can currently still do that. But as I was sitting here when the meeting first started, and it was almost a blizzard outside of my window, that's Vermont. It makes it hard for people to even get the care they need, even if you get an appointment with someone. So, and I don't know what, having been part of a big healthcare system, and I hate to say this because I felt for our doctors, but they were the ones that would travel out to the smaller hospitals and have clinics there periodically, at least to get some basic work done with the patients, instead of the patients always having to travel. And I don't know if there's been discussion about that with Dartmouth. Certainly they have more resources, but being in this corner of the state, it means you have to go to Massachusetts, to New York a lot. So there can be a lot of traveling. And because I have worked in a hospital, I have more empathy for the other side of things. It's kind of a lose-lose situation a lot of times for everybody, as Matt said. He's not doing what he really wants to do. The patients aren't necessarily getting what they want either. So I don't know. That's just overall, we've been happy. But I don't know. Well, who said it? Oh, Wendy said about sitting in the parking lot so she could have connectivity. That's another issue that I don't think has been brought up. I don't live that far out of Bennington, but a lot of times we only have one bar. So I know for many people that it's been a problem. So how can you have teleconferencing and various things like that if you can't teleconference, for instance?
So a quick question just about that. Vermont does have an effort to get broadband to various people's homes. And when I looked at the census data, and I don't remember Bennington especially, I have it written somewhere, but overall, it seemed like roughly 80% of people in the state had a computer And it wasn't much below that, maybe 75% or so, that said they had told the census people that they subscribed to broadband. And and I live in a small town north of Worcester, as you know. We just got broadband here 4 years ago, right? And I'm in an area like you where cell reception's lousy, but so cell reception could be lousy, but you can have broadband. Are you in that situation?
No, we have good connectivity.
Okay.
Personally, but I was just saying in general, I think it's maybe not so much in Bennington County, but the state as a whole.
yeah.
I'm sure you'll hear more about it.
Right. No, thank you. Appreciate that. Also, very much the comments about how to get medical records to and from and interoperability. And, my wife works at one of those big Boston hospitals too. So it's a different world from rural Vermont or even rural Massachusetts.
It is. It's different, but a lot of it's the same.
Yep. Thank you for.
I don't think people should be deluded into thinking that it could be any easier to get an appointment with a primary care physician in a Boston hospital than it is here. Truthfully, or a specialist, or even the hospital I worked in had a dental clinic for a long time, and they finally closed it. It was, they decided they couldn't be all things to all people. So had to be selective, and that's in a different environment, certainly, but there's a lot of crossover.
Right. Thank you very much.
Sure.
And also appreciate the comparability to a much larger city with thousands of more doctors than there are in Vermont. Ms. Ms. Jones.
Hi, I just wanted to add one more thing about testing and sometimes what I feel like is unnecessary testing.
Right.
I recently had, and again, this goes with cost of when you're having to pay these bills. I had pneumonia. I was diagnosed in the ER on a Monday, really early. The following week, I was 2 days better, finished. I was on 2 different antibiotics for it. 2 days after finishing the antibiotics, I went to urgent care because the breathing pain started again.
Mm-hmm.
I totally understood the chest x-ray, but they drew blood to test for bacterial or viral infection,
Mm-hmm.
which I'm not a doctor, so I could be wrong, but to me that seems unnecessary. At least it should have been brought up if I wanted it. I just finished antibiotics. I obviously had an infection. When I was diagnosed with the pneumonia, they didn't even do that test. They did a test and checked my blood cell, or white blood cell count, all that stuff. But I guess I don't understand, because this is now a bill I have to pay of why certain tests get done. I've also gone to urgent care and told them I've already taken an at-home COVID test, but then they still will do a COVID test. And then I have the COVID test on my bill.
Okay.
Yeah. So that's
Okay. Understand, and over testing can be a problem. I couldn't comment without a lot more detail you don't want to give in public. But certainly, there can be over testing. There also is under testing.
Yes.
Both present issues. So, but thank you for the comment. We'll take it into consideration. Appreciate that.
Yes, thank you.
Mr. Williams.
There you are. Can you hear me?
Yes, sir.
Good. There has been a lot of discussion both in the chat and as well by various participants with regards to medical records and with regards to access to information and the like. And it occurs to me that because, and as importantly, Trey mentioned what our hospital here in Vermont, in Bennington, is doing with regards to Epic. It's been my experience that the ability to access information in one place as opposed to multiple portals
Right.
multiple portals is problemsome for patients. And education to the level of how to access this information so one can become informed about oneself is essential.
Yep.
And the sooner and the better, and obviously it's going to take the time. But moreover, some of the portals will deal with some things, others will deal with other things. And for the average bear, I'm reasonably astute as relates to computers and the like. I can figure that out with passwords and for all the rest of that. That's not a problem for me, but it is frustrating. And if an individual who is not familiar with computers, so this gets to education, it gets to all of this as relates to the rollout of Epic and as well Athena and the various portals that Southwestern Vermont uses and Deerfield Valley uses and so forth and so on. It becomes essential to get that education out there and not out there, just literally that this is something that people are going to have to learn so that they can help to treat themselves as part of this.
Okay. Thank you. Again, a real problem. I'll share a story with you for a moment. Years back, I had an elderly great uncle who had been a policeman, had a cancer on the back of his neck, was seeing 7 doctors, and the only guy who knew what medicines he was on was my uncle, because he carried on the back of an envelope all of his medications listed. So unfortunately, times have become more electronic, but probably not a lot more efficient or effective in transferring information between docs, as we're learning here from all of you. But thank you, appreciate the comment, and hopefully one of the solutions is not to have to educate everybody on multiple platforms, but how to get an access point that simplifies that. So thank you.
Aggregation, exactly.
Yes, sir.
Aggregation of information in one place for a patient to be able to utilize.
Right. Wish we had a Google for healthcare for that purpose.
Well, I wouldn't say Google's the right way to go,
No,
but perhaps Epic will help us in that regard.
Yes, sir. Thank you. Other comments or experiences, please. Are there any public comments that anyone would care to make? We offer that opportunity. I'll go back to the phone in a minute, and then if we don't have more comments, we'll give you all time to get to dinner. Any public comments? Or comments from the telephone?
This is Mary Moore.
Yes, ma'am.
This is Mary Morrissey on the phone, and I just have to agree with many of the comments that were made today in regards to the dental issue, mental health, the substance issues, the treatments. There seems to be quite a number of areas with disconnect or that are very hard to get through the system. I won't personally go through what I did about a year ago with my own health issues that were very challenging, not only here at the hospital, but then I had to go to Dartmouth. But I hear also for a time here at our local hospital, we did not have an oncologist. And so many of the cancer patients who I know quite a number of were having to do even some of their treatments a couple of times a week over at Dartmouth, which means they're 2.5 hours over, 2.5 hours back on a day that they're having a treatment. Not only is the cost of going there pretty tough with the gas prices and that, it's pretty draining by the end of the day getting back after you've had treatment. There are a number of disconnects that way, but also when I was having my medical issues, I had to go over to have several surgeries over in Dartmouth. And I went through a lengthy year of ups and downs here at the hospital here. You know, the folks were good, but we could not diagnose for some time what was going on. And then I was sent to Rutland, who did pretty much nothing for me. And then finally I was sent to Dartmouth. And then in Dartmouth, I had where they broke my femur bone in 2 places and removing a hip replacement. So there seems to be a lot of, again, disconnect and folks not always communicating well on some of the health issues that you would think would automatically be coming from a doctor's office to a doctor's office. And so, and even in our emergency room, I've got to tell you, and I'm hoping with the new emergency room, some of those challenges will be corrected, because the emergency room was extremely challenging several times when I had to be there. And I'm normally not someone who looks to complain or that. I'm usually a pretty easy patient, but it was pretty challenging, some of the aspects of the emergency room. So I will look forward to see hopefully improvements going on there.
Could you please expand on that a little bit? How could things be improved?
Well, okay, for instance, I was asked to be at the emergency room one morning, and I was dealing with a viral infection. They finally decided, after being in 3 hospitals, that I had a viral infection in my hip replacement that I had done 5 or 6 years ago. So I was asked to meet 2 of the doctors, an orthopedic doctor from the orthopedics here in Bennington, which I did not have them as a doctor, and also our infection control doctor, who's excellent, Dr. George. But the day I arrived, and they said, you know, be there at 6:30 in the morning, that was fine, no problem, I was there. But I virtually had no care until about 11 o'clock or 11:30, and by then I was in so much pain. I said to the person, my family member who brought me, I said, I've got to get out of here. I mean, I feel worse than when I came in. And both doctors could not make it in to see me. So I virtually stayed there in the room on a gurney. And finally, the doctor that was on call, or was there not on call, was in the emergency room, said, well, we don't, you know, I think they have unfortunately, a drug overdose come into the emergency room, and I understand that takes probably precedence. But it was like, then the doctor said, well, we'll send you to Rutland Hospital. And I said, well, what are we going to be doing in Rutland? There's no plan here. What would I be doing in the emergency room in Rutland? So there were a number of disconnects there, and I think it just added to the, I would say, the kind of the upset of not being well, and, you know, kind of being, you know, we'll put you here, we'll put you there, but kind of not having a real plan to go. And I'm sure because of the lack of doctors, and I think that day that I was there, I'll, you know, be brutally honest, I think there was only one doctor in the room, in the emergency room, and I think several more came in when the overdose came in. But, you know, that's a tough thing for one doctor to be dealing with. And actually, it wasn't that busy of a morning either. There were less patients than I've ever seen there. So I'm sure, as I said, I know they've been dealing with the stress of having, you know, being able to acquire the medical staff that they need. And so I get that, and I don't say it as a negative, but those pieces have to be corrected, because otherwise it makes it very difficult for not only the patient, but the cost and everything just continues to go up, because you kind of feel like you're being put here or put there, so it looks like we're doing something for you, but we're not getting to the actual, what your health issue is. And mine took a number of several months to really figure it out after being on a portal, having intravenous treatments every day, and that we still had significant problems. So I just say there needs to be a better connect.
Thank you very much for sharing that experience and the specifics. Greatly appreciated. Ms. Jacobson, you have your hand up, I think.
Yes, thank you for allowing me to speak a second time, and I'll be quick, but I just think that after listening to what everyone has said here today, that many, if not most, of the issues that were discussed really boil down to dollars and cents, and that I would hope that we could look at a single payer system where the administrative costs, which eat up a lot of our care money, is wasted on, could be changed by having a single payer system. And we really need to look at that very seriously.
Thank you. Thank you for that comment. Mr. D, I think you had your hand up earlier.
Yes, Bruce, I just wanted to, just take this opportunity to thank all the community members today for the feedback, observations, and recommendations. I mean, as you all know, this is a very challenging time to be in healthcare, especially in with a small health system in rural Vermont, which where there is certainly a limited amount of resources. But we take your thoughts, comments, and observations very seriously. And I will tell you that virtually everything I've heard today, we are working on, and we're working to make the system better. And I think our despite the challenges that the hospital has been recognized, it's a 5-star institution for Medicare, and there's not that many of those across the country. But we know, working with Dartmouth and working with other partner hospitals, we can do better. And we're going to strive very hard to do that. So I just want to let you know, I appreciate your feedback, and I want to thank you, Bruce, for your skillful facilitation here. This was a very good session for us to hear.
Yeah. Thank you, sir. I will tell the community, I've spoken with Mr. D and his team, and they have mentioned, I think, all of the issues, or at least 95% of them, that you've given. And so I can assure you the hospital folk are aware, and part of our job is to see how we can help them out and help you out. So I'll ask if there are any further comments, and then we'll share how to give us more information and let you guys try to get to dinner. Any further comments? Okay. Could we go to the last slide, please? This just gives, we do, I guess, a couple things. One, we have, I think, another 3 statewide community sessions, and probably 8 or 9 more of the more hospital-oriented ones for the community. Sign up for those is available in the Times on the Green Mountain Care Board website. So if you or your family or anyone else have other comments they wish to make, would encourage you to get signed up and participate in one of these sessions, which, by the way, has been very helpful. If you want to direct written comments, they can either be public or you can make them private or anonymous. And those experiences should go to the website gmcboard.vermont.gov. And that's certainly available on their website as well. We do get all those comments. We will take them into consideration with these comments and the other ones we get as we try to help the hospitals and the state and everybody figure out better ways to get care to you all and to make it more efficient and so forth. As I commented, I think at the start, we are not looking at the hospitals in isolation. They can't control what happens to you all before you get to them or really after. And we want to take that into account and what those changes will need to be and what their impacts will be on the hospital. So in that vein, we really, really appreciate this. There's a question about the slides. I think the slides are on the website. If not, we'll make sure we put them on. Thank you for that question. But again, thank each and every one of you. Appreciate your time, particularly your experience and thoughts. And we will look forward to seeing many of you in person sometime in the spring. So again, thank you very much, and I wish you all a good evening.
Thank you.
Thank you.